No mai, haere mai. This presentation focuses on Section 6 of Ngā Paerewa Health and Disability Services Standard, specifically addressing the topic of restraint and seclusion within the New Zealand health and disability sector. My name is Jo Noble and I'm a Principal Advisor in the Health Cert team, and I'll be guiding you through this presentation today. This is a pre-recorded session created in response to feedback from the sector. If you have any questions at any point, please feel free to contact HealthCert at certification@health.govt.nz. This section, Here Taratahi, focuses on restraint and seclusion. It's an area of significant importance, emphasising the rights and well-being of everyone accessing health and disability services. I'll begin with some background on the Ngā Paerewa standard. The Health and Disability Services Standard, Ngā Paerewa, came into effect on February 28, 2022. It was approved under the Health and Disability Services Act 2001, replacing several previous standards that covered different service areas. The full review process leading to Ngā Paerewa took over 2.5 years of extensive consultation and drafting before finalisation. It reflects the shift towards person-centred and whānau-centred health and disability services, in which people are empowered to make decisions about their own care and support to achieve their goals. The Paerewa Healthy Futures Act 2022 mandates the health sector to operate under the principles of te tiriti by ensuring equal access and results for Māori, enhancing Māori engagement for better health outcomes, and delivering high-quality services to Māori. HealthCert has developed 2 e-learning modules to support health and disability service providers to implement the criteria linking to cultural safety within Section 1.1 Paerewa and throughout Ngā Paerewa. The first module is a high-level introduction to te tiriti o Waitangi requirements in Ngā Paerewa and how to meet the intent of those criteria, while the second module is primarily designed for senior and executive management and leaders from health and disability service providers. Frontline health and care support workers who have regular interactions with people and whānau using services will also benefit from taking this course. You can find the links in this PowerPoint attached to this presentation. We encourage you to access and complete both modules. I'll be providing an overview of Section 6 of Ngā Paerewa, which covers the topics of restraint and seclusion in health and disability care settings. This section has 4 subsections we'll look at: restraint processes, safe restraint use, quality review procedures, and guidance around seclusion. The standard emphasises a person-centred and te tiriti o Waitangi based approach when considering restraint or seclusion. It expects service providers to actively minimise restrictions to personal freedoms, offer care options focused on liberty and choice, enable workers to fully explore de-escalation alternatives before resorting to restraint and seclusion, and partner meaningfully with Māori communities on culturally safe practices that are least restrictive in nature. This sets the tone and expectations around the topics covered in Section 6. It's important to clarify the definitions used for restraint and seclusion in Ngā Paerewa. Restraint refers to any intervention, physical or otherwise, that actively limits a person's normal movement or freedom. Remember, even if a third party consents to the restraint, it is still considered restraint. Sedative medication use is addressed in subsection 3.4. The key message is that all medications must be prescribed for valid therapeutic reasons. Using medication to force compliance or render someone incapable of resistance is classified as chemical restraint and is a breach of Ngā Paerewa. This table offers practical examples of what constitutes restraint and what doesn't, categorised by personal, physical and mechanical, environmental, and chemical restraint. Please review these examples carefully to understand the nuances of restraint in various situations. Seclusion means placing a person alone in a room or area that they cannot freely exit from. This is considered the most restrictive form of environmental restraint and is governed by Section 71 of the Mental Health Act. It's crucial to note that providers should only use seclusion under urgency or in emergency situations once all other less restrictive options have been tried or where other less restrictive options are not possible to maintain the safety of tangata whaiora and staff. While the Mental Health Act permits seclusion, we now understand that seclusion has no therapeutic value. If seclusion cannot be avoided, staff have a duty of care and accountability to mitigate the potential psychological and physical harm that seclusion can cause. It is essential that it is used safely and under the appropriate circumstances. When looking at reducing restraint usage and working towards elimination where possible, the standard emphasises the importance of effective leadership. So think of a setting free of seclusion and restraint. How do we get there? Well, it starts at the top with strong, committed leadership. We're not just talking about avoiding risk, but fostering an environment that's supportive and respectful of cultural safety. It's important that those in charge are visibly committed to eliminating restraint. The role of the executive leader, whose job it is to ensure this commitment, needs to be under constant review. And let's not forget, embracing cultural appropriate care and promoting equity is a game changer in effective governance. Every instance of restraint, no matter how small or large, needs to be documented. It should include sufficient auditable details, the type of restraint, how long it lasted, why it was used, how the individual reacted, any injuries or adverse events, and the steps taken to de-escalate the situation before resorting to restraint. Each of these episodes should be thoroughly examined by a specific committee or group. This data isn't just for record keeping, but to identify patterns or trends. These insights can be the catalyst for changing policies, guidelines, and education strategies. Policies and procedures around restraint form the core foundation for implementation. Regular check-ins on your restraint policies and procedures are a must to ensure they align with Paerewa, relevant laws, and best practice. Your policy needs to reflect the commitment to reducing disparities, enhancing outcomes for Māori, and working towards restraint elimination. It's also crucial to clearly define roles and responsibilities, particularly for restraint coordinators and executive leaders. You want to create a culture that's constantly improving. That means your knowledge and skills related to minimising and eliminating restraint need to be sharp. As part of this, restraint training should be front and centre in your staff orientation education programs. Keeping tabs on staff competency is also vital. Having a regular check-in on the effectiveness of your training programs to ensure they're up to date and tailored to your organisation's needs is also important. Now that we've covered the implementation basics, let's move on to some real-life case scenarios from completed audits. These cases will highlight both successes and areas for improvement, providing valuable insights for your own practices. The first case example demonstrates the gold standard for upholding a minimal restraint approach centred around the well-being of residents. It depicts an aged care facility where leadership establishes restraint elimination as a key policy priority. Thorough assessment, informed consent, and monitoring processes minimise restrictions. Staff are actively engaged in minimising restraint through specialist training. An unwavering organisation-wide commitment and cultural partnerships with Māori communities enabled this provider to successfully maintain a restraint-free environment. Progress isn't always straightforward, however. In this second example, while the provider actively works to minimise restraint, some use is still necessitated at times to assure patient safety. This case shows fantastic practice both when restraint becomes unavoidable as well as in longer-term reduction efforts. Comprehensive assessment and approval protocols are followed, with an emphasis on consent, cultural needs, and least restrictions. Very robust documentation, reporting, monitoring, and staff debriefing procedures also enable accountability and quality improvement efforts. This allows the provider to responsibly uphold safety while progressing towards minimal usage. Our third case delves into quality review best practices for restraint use. This provider has a dedicated committee that regularly reviews any active restraints. They incorporate medical, nursing, and cultural perspectives within this committee to enable holistic evaluation. Outcomes get recorded in a central restraint register from which comprehensive reports are generated and shared across the board, staff members, and other stakeholders. Additionally, a specialised team uses behaviour data to actively minimise restraint use through positive behaviour support programs. Individual resident debriefs and engagement also help drive improvements. This last case looks specifically at seclusion elimination within a mental health facility which requires additional considerations. This provider implements updated policies aligned to Paerewa that emphasise prevention and de-escalation alternatives over utilising seclusion. Environmental changes, improved procedures, specialised staff training, stronger consumer partnerships, and culturally target efforts showcase their commitment to creating open, less restrictive treatment environments. Ongoing data monitoring, trend analysis, and plan refinement help them sustain progress towards eliminating seclusion altogether. For proper adherence, it's important to touch upon the legal context as well. Key pieces of legislation that are relevant to keep in mind around restraint and seclusion include the Mental Health Act, as well as sections 41, 48, and 151 of the Crimes Act, which relate to use of force provisions. I won't dive further into the legal details now, but it provides helpful context. For those seeking to delve deeper, we've compiled a list of useful resources, including guidance documents, best practice guidelines, tools, and cultural resources related to restraint and seclusion. That brings us to the end of this presentation overview on the Paerewa Health and Disability Services Standard as it pertains to restraint and seclusion. Thank you for your attention and engagement. Please direct any remaining questions or points of clarification to certification@health.govt.nz. We appreciate your commitment to learning about these critical service aspects that deeply impact care quality and outcomes.